Welcome everybody to the session on radiation oncology. We've got two excellent speakers lined up this afternoon. We've got Sarah Lee. Sarah is going to talk to us about plaque brachytherapy in the Sunshine State of Queensland. And then we've got Claire Phillips, who will be talking to us about stereotactic radiosurgery.
Yeah.
But first up is Sarah. Sarah is a radiation oncology registrar at the Radiation Oncology Princess Alexandra Hospital, Raymond Terrace, also known as ROPAT, and I can see why, in Brisbane. Her ocular oncology research interest is the treatment of choroidal melanoma using ruthenium plaque brachytherapy. Over to you, Sarah, and thank you.
Hi, everyone. My name is Sarah. So this is my talk on plaque brachytherapy in Queensland. So this talk will be about principles and clinical applications, limitations and toxicities, and the effectiveness of plaque brachytherapy in treating ocular melanoma. So a bit about background. Uveal melanoma is the most common type of primary intraocular malignancy in adults, and most of it presents in the choroid, followed by ciliary body, and then the iris. The majority present with localized disease, whereas less than 3% have metastases. For early stage disease, the 5-year disease-specific survival is greater than equal than 85%. However, if there is distant metastases, that drops down to less than 20%. The majority of patients have symptoms on presentation affecting their vision, or they have irritation or pain of their eye. And then 13 to 30% are asymptomatic, and the diagnosis is made incidentally. So local treatments are effective in preventing local recurrence in the majority of cases. Those treatments include surgery in the form of, say, enucleation or exenteration, laser therapy or radiotherapy, either as plaque brachytherapy or external beam radiation. There is a very famous trial called the COMS randomized trial of iodine 123 plaque brachytherapy versus enucleation. It shows no long-term survival differences between iodine plaques versus enucleation for small to medium-sized choroidal melanomas. So this is very important because we want to treat the cancer and we want to preserve the eye. So before we see the patients, we need information on the cancer itself, on the tumor itself. So we need to know the size, the diameters of the base, the thickness, the presence of orange pigment, subretinal fluid, the distance from the tumor to the optic nerve and the fovea. Other features such as extraocular extension and ciliary body involvement are also important. So these tumor factors are obtained by the ophthalmologists. There would be visual acuity tests, indirect ophthalmoscopy, fundus photography, ultrasound, and optical coherence tomography to look at the subretinal fluid, and fundus autofluorescence to look at the orange pigment. During the workup, biopsy is not always performed because it is an invasive procedure, and there's always a risk of tumor seeding with the needle. And finally, if this is a cancer, so we have to stage it properly. PET CT is performed for the whole body. MRI scans of the local regional orbit region and the liver are also performed. The liver is because uveal melanomas can spread to the liver. So plaque brachytherapy is given as an upfront primary treatment or as a salvage treatment if there is local recurrence limited to the eye. This treatment involves a multidisciplinary team, ophthalmologists, radiation oncologists, and radiation oncology medical physicists. So I am from ROPAT. We receive our referrals from the Queensland Ocular Oncology Service. So a case is then assigned to the radiation oncologist and physicist, and in the background, the logistics of treatment is being worked out, tentative dates are booked, We choose the plaque type, which includes the isotope and the size based on the tumour factors from the workup. And the treatment plan is generated by the radiation oncology medical physicist and signed off by the radiation oncologist. So in this plan, we prescribe a dose to the tumour apex, and we also check the maximum dose at the eye surface. And this is usually 1 millimetre from the depth of the eye surface. The patient then has an appointment with the radiation oncologist at Ropart, where we consent them for the treatment. The physicist takes the plaque and other equipment to the theatre, and the plaque is inserted by the ophthalmologist there. And then the patient is admitted to a single room ward in the hospital for a set duration, which is determined by the tumour factors, the plaque factors. The admission time is usually 2.5 days or more. And then afterwards, the patient is taken back to theatre, the plaque is removed, and the physicist takes the plaque back to Ropart, and that completes the treatment. So there are 2 common isotopes used in plaque brachytherapy, iodine-125 and ruthenium-106. The iodine emits gamma rays or photons. The ruthenium-106 emits beta rays or electrons. And this produces a very steep dose gradient if we use electrons. We prefer it because it results in less eye toxicity because of it doesn't go as deep into the eye, and it's very good in terms of radiation safety because that means the staff, the ophthalmologists and all staff in the theatre, they don't need to wear lead aprons, and the buildings don't need to have extra shielding. So if you can see the image on the bottom left with my pointer, this sort of tells us about the dose gradient. If the grey area is the tumour. If we say 100 gray is at the tumour apex, the surface dose for ruthenium can be up to 900 gray, but beyond the tumour apex, there is pretty much nothing, no dose beyond this tumour apex. Whereas for iodine, if you use 100 gray at the tumour apex, the surface dose is more than 400 gray, but beyond the tumour apex, there's still a very low dose going deep into the eye, say 10 gray. And then the picture on the bottom right is showing that we have different sized ruthenium plaques for different sized tumours. Plaque brachytherapy does have toxicities. The most common ones are eye irritation, glare sensitivity, cataract formation, retinopathy, and vision or visual acuity reduction. This is more significant for posterior tumours. Very rare toxicities include glaucoma, optic neuropathy, maculopathy, scleral thinning, or perforation, and that one is extremely rare. There's also secondary enucleation risk due to the radiation side effects. But again, all these side effects, they depend on where the tumour is located in the eye. There are also limitations with our treatment, and the 4 categories are basically to do with size. The plaque needs to be able to cover all of the tumour base as well as a 2 millimetre margin around the base. And then the depth. So different isotopes, as mentioned previously, would have different dose depth profiles. Iodine plaques can treat thicker tumours, but as mentioned in the previous diagram, there's low dose across the eye globe. And then location matters. So if the tumour is right next to the optic nerve, we are not going to be able to cover it completely with our plaque. That means there's inadequate dose to all of the the entire tumour area. and geometry matters. So the curvature of the eye globe contacting with the plaque is not always perfect. So there will always be dose uncertainties. And this is an invasive procedure, as shown in this diagram here. There are sutures to secure the plaque. Eye muscles are detached and then reattached during this process. There's pain, bleeding, infection risks, as well as anesthetic risks. And now we go to outcomes, which is the most important thing. There's no randomized trials for ruthenium eye plaques, but there are many large retrospective studies in the past 20 years. So for patients treated with ruthenium plaques, they have 5-year rates of survival of around 80%, local control greater than 85%, eye preservation rates 80 to 95%, and reduced vision up to 80%. And this is it's significant if you have a posterior tumor. So my project is on ruthenium eye plaque brachytherapy, treating choroidal melanoma in Queensland, and looking at patients treated between November 2020 to January 2025. It's pending publication, really close to being published. So I haven't put the results in the slides, but I can tell you some preliminary 6 and 12-month outcomes. Up to 2/3 of our patients have their melanomas detected incidentally with the optometrist. The local control rates for 6 and 12 months are all greater than 95%. Eye preservation rates at those time points are also greater than 95%. With regards to vision, 25% so a quarter of patients have no change to their vision. 50% of patients have reduction in vision at those time points, but a quarter of patients also have improved. And I think this is because as we treat the cancer, the treatment's working, so their vision does improve somewhat. So those are my preliminary results right now. These are my references to tell you the 5-year rates of outcomes across those retrospective studies. And I want to thank the colleagues at Ropart, my supervisor, Dr. Luke Nichols in particular, and the rest of the team, as well as the Queensland Ocular Oncology Service. And thank you all for attending this talk.
Thank you, Sarah. That was excellent. We'll have the second talk and then do a Q&A at the end of the second talk. Our second speaker is based here in Victoria. It is Associate Professor Claire Phillips. Professor Phillips is a senior radiation oncologist and Deputy Director of Radiation Oncology at the Peter Mac. Her clinical interests are in primary and secondary brain tumor and ocular oncology. She's developed Australia's first stereotactic radiotherapy program for choroidal melanoma with colleagues at the AOMA hospital, and conducted the world's first study of radiation oncology toxicity to improve vision outcomes. And she's going to be talking to us about her stereotactic program at the Peter Mac. Claire, it's all yours. Thank you.
Thanks very much, Lottie. Can I just please check people can hear me?
Yes, we can.
Great, thank you. So thanks very much for the invitation to talk. Lottie's asked me to speak about the stereotactic radiotherapy program we've got for posterior choroidal melanoma at Peter Mac. And I've put in brackets there radiosurgery, because formally the kind of treatment that we're giving, which is high doses in a small number of treatments or fractions, is called radiosurgery. So, pardon me, this about 20 years ago when the results of the collaborative ocular melanoma study became available. In that study, patients with medium-sized tumours had been randomised to either have their eye removed or be treated with plaque radiotherapy, as we've just heard from the previous speaker. And what that demonstrated was, with very long follow-up, right out to 12 years, that the chances of dying from any cause were exactly the same as was the chance of dying from eye melanoma. And this sort of reinforced what had until then been a sort of a mixed practice of either having brachytherapy or enucleation. But it confirmed that it was safe to try to keep your eye if you wanted to. with radiotherapy as an eye-preserving treatment. I'll note that this study was designed before the molecular characterization of uveal melanoma, but and so you could argue whether this was powered to find maybe survival differences for the high-risk patients. But at the moment, this is an accepted thing that we give radiation if patients would like to keep their eyes. So we just heard a bit about brachytherapy, and the way I think about how we choose which modality of radiation to treat eye melanoma, at least in Australia and New Zealand where we don't have protons, is if it's big, it's usually better to have your eye removed because of the toxicity of radiation, which means you end up getting your eye removed anyway because of radiation toxicity. But I think if you do have a large tumor and you really want to try to keep your eye, protons do have some dosimetric benefits over plaque or protons because of the way the radiation is distributed in the eye. And very simplistically, if the tumour's at the front of the eye here, lots of really radiation-sensitive tissues, normal tissues, sometimes plaque, sometimes protons, but definitely not stereotactic photons at the front of the eye because the radiation dose can't be localised enough to make that safe for those tissues. In the middle of the eye, which is actually a lot of the eye, most of the patients in this country, as I'm sure most of the audience are aware, are treated with plaque brachytherapy because most of the tumours appear in this area. But as we get more posteriorly in the eyes, we've just heard it's really difficult to place a plaque sufficiently to treat tumours, particularly if they are literally sitting over the top of the optic nerve itself. And trying to treat these with plaque is associated with a higher risk of local failure, basically because you can't get the dose where you need it. So after that COM study result became available, John McKenzie, I'm sure many people know, ocular oncologist in Melbourne, rang me up to say, oh, can you treat some eye tumours for us? And so we explored what was being done. And indeed, some centres in Europe had already started using stereotactic photons to treat eye melanoma. And we basically adapted a system like that for our centre, which I'll tell you a bit about in a minute. And I think it's really important just to also think about the expertise of the treating team, which is really, really critical for brachytherapy, for the treatment that we do, for protons. It's a really collaborative work between the ocular oncologist, the radiation oncologist, the radiation physicist, and the radiation therapist, and everybody has to really have a lot of attention to detail for good treatment outcomes. And so that's a really important thing to think about when you're getting treatment, but also sometimes patients prefer to have their eye removed, and that's completely reasonable as well, of course. So just a quick summary of how I sort of perceive the different radiation modalities. Plaque, as we've just heard, is a bit invasive. You can't put it on the posterior eye, but the side effects are really pretty mild. And in our system, a public health system in Australia, it's a pretty moderate to low cost therapy with very good outcomes. Protons are also a bit invasive because in order to define where the tumour is to target with the protons, a surgical procedure is done with ocular oncologists who place little metallic clips to mark the location of the tumour. And then that is used to help with designing the treatment, but more particularly with ensuring that the treatment is delivered accurately, because the metal clips are used in the X-ray imaging at treatment to check that the eye's in the right position. The main limitation, of course, is access. Even though proton machines are being put in widely around the world, most of them are not actually specialised for treating the eye. Some centres are trying to work out now how to use the standard radiation machine, proton machine that's used for treating other cancers to treat eyes, but the number of eye-specific facilities is actually just a few in the world. The toxicity is quite different because the, sorry, I thought I had a picture of an eye here, but I haven't, but the radiation beam is coming anteriorly into the eye. The patient has to gaze away to get the right direction for the eye, radiation to enter the eye. So skin side effects, conjunctival ulceration, eyelashes loss, corneal injury. These are all things that can happen with protons because radiation goes through the front of the eye. And the cost of running this treatment is very high. Stereotactic radiosurgery, be that fractionated over a number of treatments, we use 5 or a single fraction. Some centres use just 1 treatment on a fixed frame system. It's not invasive because we use MRI imaging to define the target. But the limitation of that is that if the tumour is very, very flat, you can't actually see it on imaging, and then it can be very difficult to localise the tumour such that you can't actually treat the patient. The acute toxicity is incredibly minimal. Patients can get a bit tired, get some watering of the eye or scratching of the eye, scratchy feeling of the eye simultaneously, but always very mild, grade 1, and really nothing much else. So it's, from that point of view, it's a really easy treatment to receive, what we call from the acute toxicity point of view. And once again, the costs within our health system are really quite moderate to low. The outcomes of radiation modalities, we've just heard about plaque. And like basically, whilst you can get published series that have various outcomes, I've put in brackets here for protons up to 20% enucleation. Essentially, if you put the radiation in the correct place and give enough dose, the probability of local control is extremely high. And if you give too much dose, the probability of injury to the eye, such that the eye develops bad toxicity, in particular glaucoma, so the eye becomes painful and needs to be removed, then you're going to have higher rates of eye enucleation. And the probability of enucleation is also influenced by the size and the location of the tumour in the eye. So this is what we do at Peter Mac. This is a linear accelerator. And we've got this is what we call a stereotactic linear accelerator, because over here I've got a picture of what's called the microleaf collimator. I'm not sure if it projects very well, but essentially the radiation, if you're looking up like this patient here at the outlet of the radiation from the beam, the treatment head here, there are little bits of metal, and the smallest of which are only 2.5 millimeters in size. And these can be moved individually to shape around a target. And they can also move whilst the radiation is being delivered. Usually we move the machine around the patient as well to continuously shape the radiation to meet the shape of the tumour exactly. So it's a very precise and well conformal treatment to the tumour. That's all very well, but how do we make sure we get the right place? So the patient's here, she's wearing a stereotactic radiotherapy mask, which is designed for treating things in the brain. It keeps the head very still, only a millimetre movement, but the eye can, of course, move wherever it likes. So she's gazing at a mirror, which has got a light here and a camera to monitor the position of the eye. So we use this setup, we call it the eye tracker, with the mask and the eye gaze position fixed and ensured it's in the right place for the measurements and for the delivery of treatment, to make sure that the eye is in the right place and we've localized the tumour correctly. So in the computer software, we have what we call a planning CT scan, which is done as you've just seen, all of the eye tracker equipment, and an MRI scan. We can't take the camera into the MRI scanner because it's a very powerful magnet, but the eye position is localized. And then we can match up the anatomy, as you can see here, CT to MRI, really, really perfectly. So we get very precise location of the tumour as long as we can see that tumour. And then in the software, so here's a tumour that we can see really quite neatly. We correlate the size of the tumour on the MRI with the fundoscopy images and ultrasounds that the ocular oncologist has sent in their referral and also their description of the tumour. Typically, we put a 2 millimetre margin around, as is done in plaque brachytherapy and proton therapy, to account for microscopic disease and setup error. Sometimes I make it even a 3 millimetre margin radially in the eye if those dimensions on the MRI don't match well with the description from the ophthalmologist, or occasionally the patient's eye moves just a little bit and I want it to be a little bit more generous. And then we get a plan produced using this modulated arc therapy, as we call it. And you can see that here is a very, very high dose going to the tumour. I've just selected the 10 gray distribution here. You can see how well localized this is. We try to keep dose out of the brain as much as possible. This a very low dose does sometimes get into the brain in order to get the beams in. But importantly, the front of the eye has really no dose at all. And this is why the patient has almost no side effects at the time of treatment, because these are all the radiation sensitive structures that early on in the treatment would notice if they received high doses of radiation. So as said, high dose radiotherapy is not very good for the eye. So at the back of the the back of the eye, what we're thinking about is the retina here, both the vessels and the nerve systems within them. The retina is a very complicated structure, obviously, so for want of a better term, we'll just call it retina. Within that, we have the focal point of the macula, which is why many of the patients that I meet have got really quite tiny tumours, because it's affected their vision much earlier than a tumour would if it was out here. And then we've got the optic nerve itself. These structures at the front of the eye are very radiation sensitive, as I said, and they can get side effects that I won't dwell on in too much detail now. But at the back of the eye, we get this constellation of problems. The nerve itself, if we give a high dose of radiation, is going to be damaged by the radiation. The blood vessels develop retinopathy, which can secondarily also make the optic nerve less healthy. And the retinal vessels bleed and leak protein and various things into the retina, which interfere with vision. Additionally, they can bleed into the vitreous and obstruct vision. The tumour probably causes retinal detachment more than radiation injury and retinopathy does, but it's still theoretically a risk. And then the poor vasculature at the back of the eye makes the eye grow new blood vessels, neovascularization as it's called, and this can lead to glaucoma and a painful red eye. So there are lots of reasons why the patient will lose vision from radiotherapy. And I don't think I specified earlier, but when we give our treatment, we do what has become a pretty standard dose around the world for stereotactic photon therapy, which is 50 gray in 5 big treatments of 10 gray per day. A lot of the proton centres use 4 doses of 15 gray all of these doses are very ablative and completely destroy these tissues as well as destroying the tumour, which is why patients with posterior tumours always have very poor vision outcomes. And I tell them that they will all lose their vision eventually in the treated eye. It does take about 3 to 5 years for that to actually happen because these tissues react very slowly to the radiotherapy. So I became a bit frustrated treating people with vision and knowing that I was going to make them blind. So about 20 years ago now, no, what time? 10 years ago now, we designed a study to see could we preserve vision by giving the radiation in a more standard radiotherapy way like we used to treat a lot of cancers, where we give it a large number, 30 times a small dose of 2 gray per day. And we know from lots of radiobiology over the last 50 years that giving small doses per day is protective of nerves and blood vessel tissue compared to giving a small number of very big doses per day. And so we selected patients who were not too old, because once you become older, the probability of losing vision becomes too high to justify subjecting people to a 6-week course of treatment. Similarly, diabetes predisposes people to retinopathy so much that it's not worth putting them through such a long course of treatment, have small to medium-sized tumours and some degree of vision. And they had 6 weeks of radiotherapy using the technique that I've just described to you. Because of that was a very significant biologic reduction in dose compared to the doses that I've described to you. I haven't gone into biologic dose, effective dose here, but effectively it was about somewhere between a 40 and 50% biologic dose reduction, so very substantial dose reduction. So we wanted to make sure it was safe. So the primary endpoint is metastasis-free survival rather than disease control in the eye. But of course, if the dose is too low and everybody keeps losing their eye anyway, you haven't really achieved anything very much. So we wanted to look at visual acuity, freedom from progression in the eye, how many eyes were removed and what was the radiation leak toxicity, and pretty standard follow-up at baseline, then 3 monthly for a year, and then annually to 5 years, although we are going to now do a 10-year follow-up. And using liver ultrasound as a simple and cheap way of doing an unfunded study for metastasis surveillance, but other investigations if indicated clinically. And what we found was we ended up including, as expected, small tumours. I mentioned before, they're often very small and they come to see me because of the disturbance of the macula, and all were within 3 millimetres of the optic nerve. So all very high risk for losing vision entirely using the standard 5-day treatment with a pretty standard range of median age, 19 to 65, and at least 5 years of follow-up. Although the results I'm showing you as the minimum follow-up is 4 years. And what we found was metastasis-free survival is very acceptable out to 5 years, 90%. These are very wide confidence intervals as it's a very small study. But freedom from local progression, we'd already had 3 eyes progress within 5 years, which is borderline acceptable, but for small tumours, a bit lower than you'd expect. And 3 eyes had been removed. And we had the molecular features of 2 of those. Unfortunately, there weren't enough cells in the tumour cells in the 3rd specimen that eye had been re-irradiated. So there were hardly any viable tumour cells in the end. But we found that all of them had this loss of chromosome 3 or BAP1 mutation phenotype if they had progressed. And that was out to 48 months. And then actually just in the last 6 months, this is not published, we've actually had a number of extra patients fail. So another 4, which is giving us a poor freedom from local progression of only 65%. And another couple of those patients have also got this poor high risk molecular characteristics in the eye of the tumour. What we don't know, well, I'll talk about that a little bit more. So just so you visually here, this is what's called a swimmer plot, and this is the 48 minimum and 5-year median follow-up, and you can see most of the patients are actually doing extremely well without recurrence in their eye. But as mentioned, we've now got 4 more with recurrence, so it doesn't look quite as pretty as it did even just 6 months ago. And then this is a swimmer plot, which is looking at visual acuity. So yellow and blue are good vision, and we've got even out here right out at six years even, 1, 2, 3, 4, 5 patients with normal vision after having full radiotherapy for their eye and a controlled tumour. And then another 3 there right out past 5 years with better than 6 on 12 vision, and another couple here. But other patients, despite having that long course of treatment, still had poor visual outcomes. And the main predictor for a better visual outcome was actually just the quality of the vision at baseline. So in summary, we can say that stereotactic photon radiosurgery has been a useful alternative to protons for treatment of posterior tumours. The visual acuity outcomes are usually pretty poor because of the location in the eye and the use of ablative dose fractionation. The tumour itself can obviously contribute to poor vision outcomes, as does the underlying vascular health of the patient. And in the study, we found that there was no doubt that using the small fractionation reduced late radiation toxicity, but it also increased recurrence in the eye compared to the standard treatment and didn't guarantee good visual outcomes, although the probability of a good visual outcome was much, much higher than with the ablative dose fractionation. And so we're in a situation now where maybe patients who have truly got low molecular risk tumours might be able to be treated with this treatment and preserve vision as well as their eye and not be at risk of getting distant metastases. But these tumours are generally ones that we don't have tissue on prior to treatment because they're so tiny and posterior, it's very difficult to safely get cells. And I suppose there's also a possibility that we know that uveal melanomas can be heterogeneous with regards to the molecular types within the one tumour, and maybe this fractionation is able to deal with the low molecular risk cells very readily, but is then selecting out residual class 2 tumours in some cells in some tumours. I'm not sure about that, but these are all the questions that get raised when you do research. Anyway, thanks very much for your attention.
Thank you, Claire. That was excellent. It's nice to see Victoria leading the way, exploring how these different fractionations can potentially change patient outcomes. We've got about 9 minutes to do some Q&A. I had a question for you, Sarah, first. You talked about the Queensland practice. Is it, and just how things happen sort of for the patient journey in Queensland, is that different in the other states? Is that something you can comment on?
Oh, I'm not familiar with other states. Apologise. I only know Queensland.
Fair enough. We've got a question in the chat from Gabrielle Byers. Thanks, Gabrielle. This is a question for the panel, so I think for both of you. How do you balance treatment benefits with potential side effects for ocular melanoma patients? Do patients typically experience similar side effects following radiotherapy? Claire, do you want to go first?
Yeah, well, I mean, I tell all my patients the same thing, that they're going to not have a difficult time to receive treatment unless they're very claustrophobic, and that they'll keep their vision, and in some cases it might even improve for a little while as the tumours get flatter, but ultimately they're going to lose their vision entirely. And I don't really have much else that I can offer them other than to say it's perfectly their choice if they want to have radiotherapy to keep their eye, or whether they would actually just prefer to have their eye removed. And some people do prefer the idea of having their eye removed. Others couldn't think of anything worse. So it's a very individualised and personal response, I suppose, to what their motivations are.
Sarah, do you want to comment on that?
Yes, I agree with that. We do that as well. I guess to the patient, we also break down our thought processes. We talk about patient tumor treatment factors. We look at the patient's pre-existing eye conditions, their baseline vision, whether it's worth preserving their vision at all. And then tumor factors, the stage, prognostic stage, the size, where it's located. And based on the location, we can tell patients roughly the probability of the side effects. And then treatment factors. Have they had other local treatments before, and did that work or not? If they come to us with previous treatments, it means the previous treatment probably has not been effective. And I think, yes, based on all of these factors, balancing them, we ultimately want to treat the cancer, but we want to also preserve vision and the globe. And I think it's a joint decision, joint discussion. Yeah.
So Claire, you explained really nicely about your external beam stereotactic setup, which has, you need Linac, you need the mask, but you also need the camera setup. That's not available in all states in Australia. And is it available in New Zealand? Can you comment on that?
The group in Dunedin have been using fractionated stereotactic radiotherapy for longer than I have to treat eye melanoma. And I have to apologise, but I don't actually know what they use for ion mobilisation. I don't know if anybody's online who can answer that question themselves. But maybe something similar, not sure. There is another technique where people inject local anaesthetic into the back of the eye to paralyse the eye, as is done for ocular surgery at times. The problem with that technique is that you can't reproduce exactly the same eye position daily, so you need to replan the treatment the patient every day. So that can be used. So centres that have got a gamma knife with a frame so that they don't have a mask and they can't treat the patient over multiple days in the same position. We'll put a frame on, image the eye, or paralyze the eye, image the eye, and then try to get all the treatment done before the local anaesthetic wears off. So it's a little bit more tricky because you can't really monitor the eye in the gamma knife, so you don't know if it's wearing off, but that's a technique that is used.
We've heard a lot today, particularly from medical oncologists, about just how much their contribution to this has changed and improved in the last couple of years. So I guess a question for both of you is, where do you see radiation oncology in the next 5 years? Do you think, what big changes do you see coming our way?
Do you want to go, Annie? You go.
Okay, well, I can tell you my wish list. I think I think it's we would like more data, I guess. These cases are still very rare. I'm relying on retrospective studies to be our benchmark, and we're looking at our cases. It's only a few each year, so I think we should all work together, maybe have a national registry together. That will help us understand the uveal melanoma better, and then we will be able to be more confident with the treatments and the trajectory of all our treatments. Yep.
Yeah, national databases or registries are a really useful tool, I think.
Yeah.
I'm not sure where I think radiotherapy is going to still have a pretty substantial role in the treatment of this disease. I don't think the drugs are efficacious enough at this point that we're dispensing with local therapies, and so radiotherapy remains an important tool. I think the fantastic thing about those drugs so far is reducing the toxicity of the local therapies in a combined way, and hopefully ultimately systemic outcomes as well. I'm not sure how many of the audience are aware of the long protracted process of trying to bring proton therapy to this country. If we did that, then certainly we'd be interested in exploring whether we can explore developing a technique to treat protons, to use protons to treat eye tumours, but recognising what I think both emphasise is the importance of the team, and it may actually not be a good idea to do that if we don't have enough of critical mass of patients to actually justify doing that, travelling interstate for treatment and so forth. So, I think at the moment we've got Sydney and us doing this external beam photon therapy and a very established plaque service across the nation, which I think is really an excellent service for patients, that they can have. Most patients can have treatment in their state, maybe not Tassie and Northern Territory, but yeah.
We have an answer to your question, Claire, from Peter Haddon, who said that that in Dunedin they have a camera system for monitoring the patient's eye position. So,
yeah,
so that sounds very similar to what you do.
Same. I think it's a very good solution that works well in a Linux setup. You've got plenty of space to put the camera, and yeah.
Sarah, you mentioned a national database, and I guess it's not a national database, but a number of clinics in Australia are contributing to the Fight Tumour Blindness Registry, and that's patients treated with enucleation or plaque or external beam radiotherapy, because I completely agree that the number of patients is so small that it's very good to pool data, particularly given the heterogeneity of just how things happen clinically. We have one more question from... Sorry, that just disappeared. From Gabrielle, she says, for Claire, are there techniques that patients can use to cope with claustrophobia during RT treatment? Oh, that's a good one.
Yeah, it's a tricky one, because for our technique, we really need the patient to be fully alert. So when patients are claustrophobic with a stereotactic mark where they're not gazing at something, we give them some sedation and then relax them. But this is a little bit more challenging. So it's, again, quite an individualized approach. There are some people who just upfront say, there's no way I can do that. And then that's fine. And we've had a patient for whom we ended up using our gamma knife and the frame, because that was not as, the frame sounds freaky, but once it's on, it's not claustrophobic. So it sits like this around the head. But otherwise, unfortunately, there aren't any really excellent solutions, because if you have relaxation, like sedation medicine to relax you, you tend to be a bit more woozy, and it's hard to predict how the patient will be. Yeah, I noticed that. Okay, so we've just heard that we're not quite sure why we've lost our connection with Lottie. So we're going to round off the session. I think it'd come to the end anyway. So thanks very much from me for listening.
Thank you. Yeah.
Enjoy the rest of the meeting.